on microbial marvels transforming the fungal diagnosis. To chair this session, I call upon Dr. Ranjana Khuraijam and Dr. Anupma Jyoti Kindo. She is a professor at the Regional Institute of Medical Sciences, Manipur. She has also served as an academic research fellow in London, UK. Her expertise spans several fields, including infectious disease, infection surveillance and prevention, infectious disease epidemiology, tropical diseases, tuberculosis, and sepsis. Dr. Ranjana has authored 43 scientific publications, contributing significantly to her field of expertise. Now our second chairperson is Dr. Anupma Jyoti Kindo. She is Professor of Microbiology, Sriramachandra Medical College and Research Institute, Chennai. She has 21 years of experience. Her areas of focus are microbiology diagnostics for patients, teaching undergraduates medical, dental, and paramedical courses in microbiology, research guide for MD, MSc, and PhD students. She specializes in mycology and the standardization of PCR for diagnosing Mycobacterium tuberculosis, possesses thorough knowledge in handling PCR processes and sophisticated instruments associated with it. She is life member of numerous prestigious national and international societies. She is recipient of several awards, including Best Publication Awards and fellowships from various institutions. She has authored more than 40 scientific publications. Now I hand over the mic to chairperson.
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank that at least mycology has been put into a symposium here. And I have got very important guests along with, in front of me, Dr. Rajiv Sumant, a great clinician. Friends, I am going to discuss the threat which we are getting from Candida auris. You know that it's not no more the history of Candida albicans or tropicalis, rather unusual pathogens across the globe is coming up. And if you see all the pathogens which are coming up, on the top it is the Candida auris. You all know the story started in 2009 from a lady. She is from Japan. From her ear, it was the first time isolated. But within no time, you can see that in 2022, throughout the world, it had been found that Candida auris is there. So what is this peculiar agent? This is one fungus which is just behaving like bacteria. Because you develop resistance very fast. Fluconazole 100% resistant, voriconazole nearly 50% resistant. You see, this particular pathogen colonizes just like an MRSA. Colonizes in the skin, colonizes in the nose. And I still remember when I was a student that time, if there is an MRSA isolated, the whole ICU is being closed. But now MRSA, we know about, this is community MRSA, hospital MRSA, all these things are there and nobody bothers about it. Possibly people started feeling the same thing about Candida auris. And you see the colonization to decolonization is very difficult. Months, years it may take. It contaminates the environment very fast, and we see that within no time, in the whole hospital, you can see this agent. Hardy fungus. You see, this fungus, usually we see yeast, they colonizes on the moist surface. But this fungus can live in the linen, dry linen from days or weeks together. It prevents a lot of killing or resilient to the disinfectant which is being done. It produces serious disease, difficult to identify and difficult to treat. So, Fred, what is the good about this particular agent? Let me know about it. Everything bad in this agent, and that's why it's causing outbreaks. And if you see, each of these dots is an outbreak. And maximum outbreak happen in case of the Asia. You see, now in India, like MRSA, we see Candida auris has become endemic in situation. And this endemicity has come because of patient carriage and environmental contamination. This is the first agent, fungus, which have been put under urgent threat category under CDC. And you see that when we first time did this study of across the India, 27 ICU study, we said that Candida auris has come. It is in 2010-11, it had entered in India within 1 year. But nobody paid any attention. That time we said that it is the 6th rank in order. Until unless our big brother USA says that this agent you look for, nobody pay any attention. Thank God at least they have put it under urgent threat category. So you see in 2020, this city, Pune, it had shown that Candida auris is now the 1st rank in order in bloodstream infection. In Delhi, the same scenario which have been shown. When we have this COVID, we have seen there is this big surge of candidemia, twofold rise, and you see 40% was in case of the Candida auris. Very recent paper, 67 Indian ICU data which have been published, it had shown the same finding. Not only candidemia, even in class C, the same situation which have been shown, and it had shown again, this is the 1st rank in order in bloodstream infection which has been there. Coming to the pediatric population, same thing. When we did the study early, it was quite low in incidence which have been there, but you see slowly Amrita, in case of the Ramchandra Institute, in case of Tonu Singhal from the Mumbai, she had shown that this Candida auris is the commonest species encountering about 37% of invasive candidiasis and 66% neonatal invasive candidiasis. Friends, this is at least at the beginning, Indian Council of Medical Research was very responsive. They put this on their website that if there is Candida auris, please inform the reference center at Chandigarh. And people were at the beginning used to really contact us immediately, even if one isolate was there. But slowly, people were become complacent because administration was not paying any attention. So you see, there are so many outbreaks reported from Jaipur, Uttarakhand, Assam, Rajasthan, wherever not, everywhere. And you see, they are mostly resistant species which have been there. Candida auris, we know about the 4 clades at the beginning, and the 4 clades independently came out. And our clade, which is being seen in South Asia, that is clade 1. And in case of the Japan, from where it came, it was clade 2. Clade 3 was in case of the, mainly in African region where it was there, and clade 4, which have been shown at the time in South America. But friends, now we have clade 5, clade 6. Clade 5 in case of the Iran, which have been shown, and clade 6 had been seen recently from Singapore first, but very recent study from Bangladesh, it had shown both clade 1 and clade 6 which have been present. Look at this clade 1, compared to all of them, highest drug resistance which have been seen, and that is seen in case of the India. Even in case of the virulence comparison, whether it is murine body or in case of Galleria, it had shown that the highest virulence is seen in case of Candida clade 1. Now, the thing is that what is happening, I am just saying that the 3 outbreaks which have been really controlled in India, let's try to learn from that 3 outbreaks. The first outbreak happened in our own center at PGI. You see, one patient entered in the trauma ICU. Within 4 days, all the patient colonized, all the patient. And you see that it had been seen also in the hands of the healthcare workers. So ultimately, we had to improve the infection control practice. That really helped. In case of the decolonization, we used to do chlorhexidine body wash. Some of the patients took months to decolonize in that sense. Then there is this Patna outbreak. Again, in case of the neonates, it had been seen, and it had shown again that the infection control, when they have improved, that had really helped. Amrita Institute, this outbreak had been really detailed studied. They have first outbreak when they developed the team. Team having clinical microbiology team, if there is Candida auris, immediately inform. Who will be informed? Infection control team. In case of this infection, even in case of the all physician, and also you have to inform the antimicrobial stewardship team. And they used to all function together. And here you see, ultimately they had to do the contact precaution, restriction of the visitors, and all these things like PPE, optimized therapy, all these things have been done. So friends, what is the lesson we have learned from these three outbreaks? One is that this should be reportable disease. I think government should seriously think about mentioning it is a reportable disease. It contaminates the environment very fast, avoid equipment sharing, and use only effective disinfectant, needs to improve IPC, all these things are required. So, suppose if you want to completely prevent Candida auris entering in your ICU, what you have to do? Or suppose if you have already entered and you want to get rid of it, what you have to do? Generally, you have to first need to know who are the persons they acquire Candida auris very fast. It had been studied, case control, multiple studies had been done. It has shown that it is similar like Candida. Only thing, if the prior antifungal drugs use has been found to be important. Also, it had been seen if the patient staying for a long time. So, any patient with sepsis in ICU undergoing invasive management for longer period and exposed to antifungal, think about whether this patient can acquire Candida auris. Now, you need to diagnose or identify Candida auris, how you can go. Phenotypic method, Vitek, API 220C, all these things were not successful. So people were depending on MALDI and sequencing. But you know how many of you have MALDI at your center. So that's a big problem. But now BioMero claimed that Vitek 2 yes, this particular software can identify. I have no experience, but you people who have used it can say about whether it is able to do. Already firms, Gangaram, yes, they can identify with it. And also the BCID panel that can help. We developed a simplified medium that for your people who have nothing in that sense, if you prepare high concentration of sodium chloride with high concentration of ferrous sulfate, incubate at 42 degrees centigrade, it is Candida auris which selects out in that sense. But friends, I said that we are going to prevent entry of Candida auris. If you have to prevent entry, you have to screen any patient who is coming to your ICU. So you cannot wait for so long period, we need quick. And we all know Chromagar is there, and this is the new Chromagar which had come, and it had shown that it really identifies and separates out Candida auris well. But in this case also, you need 24 to 48 hours. So ultimately, we have to depend in case of this molecular technique, and it had shown that in case of this, one of this from the OLM, they can identify it in 1.5 hours. I have seen in the exhibition, one of the companies said they can also identify. Whatever it is, let's try. This can really help. So friends, if we have to prevent this aspect, first thing is that we need to know the colonization, where are the sites, and if you can see a patient coming in your hospital, and if you can do a swab, axilla, naos, and groin, and if you can try to look into, just keep the patient at a corner for a 1 to 1.5 hours. If it is not Candida auris, please allow the proper entry in that ICU in that sense. One important thing, any high colonizer or high shaders, you see, everything can be contaminated. And it had shown that, I have just said that even dry things can be contaminated. It had shown by that. And sharing of the equipment is a big issue. Like there is a big outbreak which happened in case of UK, which had shown to be linked with the thermometer they used to use. Here you see, if you do oximeter use, if you do the blood pressure, these are the things which can really help in case of contamination. So it can come from the patient, it can come from the healthcare worker, it can come from the environment and cause it. Very recently, it had shown that, like NDM, you go to look into the sewage, whereas the NDM is there. Similarly, you can do same type of things in case of this Candida auris. In a city, if you are looking into the sewage water, you can try to it because it is getting enriched in that. high concentration of sodium chloride, it get enriched. So this particular technique, when it had been used in USA, you see the comparison, whether it is number of cases plus wastewater, there is good correlation had been found. And so when there was the Nevada outbreak had been there, they could look into this, look 91 samples, 72 were positive, and they were all where there is the outbreaks were there. Next, from the Nevada, when the outbreak had gone to Ottawa, they have seen the same thing. It had gone, and you can see pinpoint from the wastewater that this is being there. So if you have to control, you have to go from the same transmission-based precaution. You have to do admission screening if possible. If the patient is already colonized, keep in the isolation. I know it is not so easy in most of the hospital to give them a separate room. You can put in a corner, you can flag it that this is Candida auris patient, so that at least people become more take precaution while handling this aspect. You have to do environmental handling, hand hygiene, all these aspects. All these are okay. If you see the recommendation wise, there is always, in case of the contamination of the environment, there is good recommendation, hand washing, good recommendation, but decolonization, no recommendation. We still don't know what is the best way of decolonize one patient who has already been there. Lastly, just few lines in case of the management. You know, in case of management, Candida auris, only drug which is being recommended is echinocandin. Now, echinocandin also getting resistant, so you have to do a susceptibility study in this case. There is a very good study regarding echinocandin from this city again. Parikshit, he had done a very good work comparing the three echinocandins. And what he found that in cat spore resistance is very high. Most important thing what he had mentioned, that is all is important for us, because you know there are generics for all echinocandins. Now these generics, we are always being afraid whether it can work or not. What he had shown, at least in case of generic, all of them had shown to be performing the same thing which has been there. There are new drugs which are in the pipeline, and most of these working in case of the Candida auris. And here there are two compounds, first time we have come to know, which are having new sites. Because you know, in case of antifungal, it's very difficult to develop antifungal because fungus is eukaryotic, host is eukaryotic, so it's difficult to exploit the difference in case of metabolism. Bacteria is prokaryotic, so you can exploit the difference. But here that is problem. But these two compounds, one is phosphomanogepix, which is working on GTW1, and another is the T2307, which is working on mitochondrial membrane collapse. That is very important. This is a study had been done in vitro. We are not still knowing whether it really helps or not. If you see HIV protease inhibitor, especially if it is being combined with posaconazole, it had shown that it is giving very good result. So we possibly need good drug, because what we have seen is that even in case of the echinocandin resistance is coming up to 10%. Several times we have found that, okay, rezafusine has been found to be useful. Rezafusine is one of the drug which is one echinocandin, and this particular drug can be given once in a week. At least two drugs, Ibex Fungal and rezafusine, has been approved by FDA. I don't know when it will arrive in India, but there are some experience, like Rajiv must have used this, these two compounds in some of his patients. So friends, what I tried to tell you in this short time, Candida auris is a red alert in critically ill patient. It is now the first order in case of the ICU. Second important thing is behaving like a bacterium, developing resistance very fast, easily transmitted, cause outbreaks, resilient pathogen. We know what is the predisposing condition. It is same like with Candida others. Only thing is that it is the antifungal drug exposure really brings out selectively Candida auris. Erroneously identified by traditional biochemical or phenotypic tests, so we need a technique which can really identify it well. That is very important. Indian isolates are uniformly resistant to fluconazole, 50% resistant to voriconazole. Even echinocandin has started to be resistant, so we need new antifungal. Basic infection control practice like hand hygiene, transmission-based precaution, and environmental cleaning are the most important. We need to improve the cleaning techniques. That is very important. That is the way you can prevent Candida auris. At last, I say that from our fungal infection study forum, we are running the fungal registry. You can submit your cases to this fungal registry. If your cases is accepted, we compensate with 2,000 rupees per case. So this is very important for the knowing about the Indian registry of fungal disease. Thank you for your kind attention.
Thank you, sir. Posaconazole has
You know, posaconazole, the problem is that this is being developed by MSD. And MSD, they, when found this posaconazole is very good for antifungal prophylaxis, they are very happy. You know, any drug which can be used in prophylaxis market is there. So they never tried to do studies in other area. But I have seen where nothing can be done, I say try posaconazole, and it has seen that whether it is Demeticious fungi, whether it is some rare mold, posaconazole works well. You know, posaconazole get concentrated inside the macrophage. That is very important thing which have been shown in this aspect. So, please, this drug, I know that they have not recommended anywhere, but you see, so many times we have used posaconazole.
okay, sir. We also did MIC, antifungal micro broth, and we found good very low MIC.
Yes, any drug which is less used, you will get good
low
drug,
MIC only.
good susceptibility.
Anybody has any other questions?
Sir, thank you for the wonderful talk and great learning. Sir, you said it is like a bacteria. So can we expect it to become a community-acquired agent in near future? Community acquired.
Acquired. See, community, you know, it had been found like, there was a study which had shown in Andaman, it had been found in one. Generally, when people have looked into in every environment, Candida auris is still not being found. It's a, you know, really something had been found somewhere. But community acquired means it is persisting in the community. We have not till now found it is in the community. It is in the hospital where from Candida auris comes. Possibly very soon people will go back with colonization from the hospital and can infect in the local people, and then that would be community acquired. Till now, it had not been found to be isolated. There are very rare case reports there. It had been isolated from this particular community and this aspect. But you see, to claim that this is community acquired is not community.
Thank you.
Rajiv, want to say something? Achha.
Thank you, sir. Now we call upon the second speaker, Dr. Shivaprakash. He is a professor of medical mycology at PGI Chandigarh, and I will make it very short. He has held roles as President, General Secretary and Treasurer of ISMM, and he is a Fellow of the National Academy of Medical Sciences, and his research interests include molecular epidemiology, typing and taxonomy of human pathogenic fungi, molecular diagnosis, antifungal resistance. And he has identified many rare fungi as agents of mycosis and discovered new species of fungal pathogenic to humans, such as Malassezia arunoloke, Exophial arunoloke, and Cunninghamella arunoloke. With over 260 peer-reviewed research papers, Dr. Rudramurthy's contribution to the field are substantial. Over to Dr. Shivaprakash.
The organizers of the MicroCon 2024. So I've been asked to speak on advances in the diagnosis of invasive fungal infections. So already sir has talked about Candida auris. So there is an increase in the incidence of the invasive fungal infection, which carries a large number of mortality as well as morbidity. So you all know the reasons for increase in the invasive fungal infections. So the most common causes causing an invasive infections are candidiasis, aspergillosis, cryptococcosis, mucormycosis, and infection due to pneumocystis, PCP. So symptoms are generally non-specific. So early diagnosis is very important, and it is often difficult to establish. So the conventional culture that we have, you all know the limitation of conventional culture, both the culture as well as histopathology. It will take time, and most of the time in case of histopathology, differentiation will be very difficult, and especially we should have an high load of an fungi within to have an to give a positivity in histopathology. So what we do have in the current methods will have an infections, for example, pathological changes when it is there, as well as when there is a clinical infection. So the method, what you have to do is here empirical targeted therapy you can give. So what really is required is we need to identify the infection at earliest. So whenever the biological infection is there, if we can detect it, then you can treat it early and reduce the mortality. So for that, you can give so that you can give targeted as well as preemptive therapy. And now we have many of the antigen detection tests as well as molecular tests for the detection of the DNA. So for example, most of the thing, this is the cell wall of the fungi. So it contains many contents. This example, manoproteins it has got beta-D-glucan, it has got an even mannan in case of Candida, galactomannan in case of Aspergillus. So all these things are can be exploited to identify it in the clinical samples to get a diagnosis. So these are all there for the long time, many of these. But now what we have is it is coming in a different format. For example, Platylia is an ELISA. So that is there for more than a decade or more than a decade now. And even beta-D-glucan more than a decade. But we do have a different format. That is an advancement that is there. For example, point of care test, we are getting this thing. So cryptococcal, you all know that this is one of the best tests for the antigen detection, latex agglutination test. So it has really gotten very high sensitivity and specificity, few false positivity and false negativity is there. But now what is the advancement is, now we have a lateral flow assay. Lateral flow assay sample, there is no need to bring it to the laboratory. So you can test it in a side lab itself, at the clinical side lab. So that is the advantage. You have a rapid turnover, low cost, and also another main advantage is in case of Candida Cryptococcus gattii. So many of the time this latex agglutination will be negative. So this particular lateral flow test, I found that this will pick up this gattii infection also. So another important thing in the development of this one is the recommendation. For example, this is one of an important study. This was even the editor has quoted that one of the best study in that particular episode journal, this one edition of journal. So they say that patients who are negative for CSF, for example, highly susceptible patient, HIV patients who are susceptible for cryptococcal infection, they say that the serum, they have to screen the patients with the serum. So when they screen it, they will pick up early and then they can reduce the mortality. So screening is recommended routinely for cryptococcus infection. So next is an beta-D-glucan detection test. In beta-D-glucan test, again beta-D-glucan, as I said, is an essential component of the cell wall, but it is absent in case of some fungus like cryptococcus as well as mucorales. So that's why this is, you can say that it is a pan-fungal test. For example, Aspergillus we can detect it, as even you can detect for, mostly it is used for the detection of candidiasis. So the principle, just for the students who are there, the principle is mainly it is just like an endotoxin detection test. It is not an antigen antibody detection test. So we use an luminous amoebocyte lysate that will be clotted, and we need to have an chyletic ELISA for doing this particular test. So here instead of endotoxin, the pathway of this one is different. So factor G is inhibited by this. In such a way they have developed this particular test. And it is also, now you can see that there are many other tests. Earlier only Fungitel was there, so they developed this test, and that is only FDA approved till now. So you can see that many other test kits are available nowadays. So whenever you have to cut off, accordingly you should take. But Fungitel is the one which is widely evaluated clinically, and you have in clinical cutoff as well as breakpoint. This one, it is very well defined. This one cutoff points have been well defined. Whereas for some like Waco, you can see that it has got 11 picogram. So beta-glucan, again, you have many advantage as well as disadvantage. You can see that it can detect an antigemia or beta-glucan 10 days before the candidemia, and even in case of intra-abdominal candidiasis, you can see it can detect very early. As well as one important thing is it has got an excellent negative predictive value. So the test which has got an excellent negative predictive value, based if it is negative, they withdraw from giving an antifungal. So that is one of an important thing that, for example, especially in case of ICU and other settings, it can be helpful. And also we can identify the therapeutic or prophylactic failures by using this particular test. So performance, there is no doubt, it has got an sensitivity and specificity of very high. And also you should remember some of the false positivity about this test. For example, glucans, cellulose containing filters. So all this leads to the false positive test, as well as false negatives, hyperpigmented serums and antifungal therapy. So one advancement here is then Fungitel stat now we have. Because this Fungitel, which I was telling earlier, that will actually, what happens is, that is a batch test. We have to have at least 21 samples to do run the test. So candidiasis is very emergency. So you have to give the antifungal therapy early. So if you delay the antifungal, then mortality is there. So now they have come up with this Fungitel, this one. So this has gotten many advantage. You can use if you have a single sample, you can run it, and the same day you can send the report. But when they have evaluated with the standard Fungitel assay, so you can see the cutoff is completely different. So if it is more than 1.2, then it is positive. So another beta-glucan detection test we have evaluated. This is already there is one stall also from Fujifilm. So when we evaluated, it is really shown that it is almost comparative with that of an Fungitel test, the standard Fungitel test. For example, you can see the cutoff is completely different. We have evaluated cutoff at a different particular point. So for 5 picogram with a good agreement of 84.7% with that of an Fungitel. So again, you can see both it can help in the diagnosis of invasive candidiasis as well as invasive aspergillosis. So mannan antigen and antibody detection. This is like galactomannan, which is present in an aspergillus. Mannan is there in a candida. So mannan has been derived from this Candida albicans, and that has been used. And even today I was talking to Rangnath Iyer, so he was using, so if you do not have this beta-glucan and other tests, so this is an platelia, just ELISA test, you can do the thing. So one important thing is mannanemia precedes 6 days before the positive culture, and it is also highly immunogenic polysaccharide. So mannan antigen, when you use the test, only antibody or antigen, both mannan antigen as well as mannan antibody detection tests are available. If you want to use it, both together you have to use it, or you have to also combine with the other detection test. So in case of fungal infection diagnosis, especially this candidemia or aspergillosis, you need to combine together clinical factors, all the other factors, as well as even different tests you have to do it in order to say it is a positive or not. This is another test, Candida albicans gem tube antigen test. So this is again to detect an antibody. So it was originally found that in Candida albicans, but now it has shown that it can detect other Candida species also. So again, like Candida mannan and this test cannot be used alone. So because sensitivity is about 53 to 71%, and specificity again 56 to 96. So you can use either with a BDG or along with a mannan or antibody detection test. Next is galactomannan test. Galactomannan is also a component of a cell wall. So you can see this particular galactomannan, why it is specific in an invasive aspergillosis. It is released only when there is when it invades the tissues. So that's why it helps in the diagnosis of invasive aspergillosis. We have a very good technique for detection, and it is an FDA approved, and the advantage, specificity and sensitivity is very good. It is galactomannan detection also has got a on the cross reaction with this histoplasma as well as fusarium. So if it will help in the diagnosis of histoplasma also. So you do have some of the false positive reaction, but at least now they say that false positive reaction has been reduced for in this particular case. And the main development is that now they come out with an lateral flow format. So IMI-SONA, so you can see that the sensitivity is not compromised. At the cutoff of 0.5 or 0.6, so 0.5 it is 96% sensitivity and 98%. So lateral flow assay. So this is one of an important thing, and also you can see that in different clinical setting it can be used. Even in case of ICU settings definitely generally they say that we should not do for screening and this one for galactomannan. So but here in ICU setting also it has got a sensitivity of about 74% and around 70%, more than 70% both sensitivity and specificity. So that is an advantage of this galactomannan lateral flow assay. So lateral flow devices, this is another, this one, it does not detect galactomannan, but it detects this glucoprotein antigen. So it has got a specificity of more than 100%, but it is said to be that better than galactomannan assay, especially as a screening test rather than a confirmatory test. So again, this particular test, you can see that especially when you try to detect it in the ball fluid, so it has gotten very high sensitivity, somewhere around 100% sensitivity and around more than 80. Again, this has been helpful in detecting, it can be used in an ICU setting also, this glucoprotein test. So coming to an antibody detection test, especially for aspergillosis, generally we do not use it for an invasive aspergillosis. But this is for chronic pulmonary aspergillosis, antibody detection is one of an important thing. So this is a new LDBio, is a new kit that has come out. Both this IgG as well as IgM you can detect by using this test. So it has shown that when we try to evaluate it with the different controls, healthy controls as well as disease controls we took, and when we compared it with an platelia, so it could show that at least sensitivity of more than 86%. So LDBio lateral flow assay can help you in detecting both IgG as well as IgM. So recommendation for this one, you can see both European Conference of Infections in Leukemia, they recommend for generally hematologic patients, hematologic cancer or neutropenic patients. In neutropenia, both from ball sample and this one, different cutoff they have given, and even this EORTC MSG, you can see that single test if you use 1.0 ball flow for ball serum, for ball 1.0, whereas for single serum plasma and ball sample, both if you have, then even at 0.7 or 0.8 if it is there, you can take it as positive. So but when you are testing this galactomannan or ball samples, beta-D-glucan, you should always have the probability of infection should be, pre-test probability should be very high. For example, in a neutropenic patient where you expect more aspergillosis, if you do it, that test, then you have a more better post-test probability is very good. If you use it in an ICU patient, then post-test probability will be very less. So whenever if you have a very high probability, then only use this test. So for mucormycosis, we do not have any biomarker till now, but still we have a promising thing. Some of the rhizopus specific antigen has been detected, and it has been monoclonal antigen has also been developed, and they say that now lateral flow is been in the preclinical trials they are doing. For especially this fucomin, antigen against fucomin we have. And this is another test our student has developed. So sir's PhD student Ansaraj. So this is detection of an antibody for in case of, which helps in the diagnosis of mucormycosis. You can see that both IgG as well IgM can be detected using by this. So if we use either IgG or IgM, if we take, so you can see that such sensitivity is about 94% and specificity is about 100%. If we use either one IgG or IgM, then comparatively it is lower. So combined test both IgG and IgM, we still need to evaluate and do the multicentric evaluation of this particular test. So coming to molecular diagnosis, I will not go into the detail. So little bit just to give you a pinch of what is happening in the molecular diagnosis. So molecular diagnosis, mainly we have two approaches. One is by using an for example, detection in the clinical sample, another is an identification of the fungi, and next is an detection of the mutation. These are the three approaches that we have. So one is an pan-fungal PCR if you want to do. Mainly we have in pan-fungal PCR any fungus that is present, and Aspergillus PCR for invasive candidiasis, mucormycosis as well as pneumocystis jirovecii. So the target is an rDNA. Most of the time we have pan-fungal has been derived within this particular rDNA region, as well as we have a specific primers that is being designed. For example, in 18S you have defined, they have designed an mucor specific this primers. So you can use that particular if you suspect a mucormycosis. Even Candida genus specific, Aspergillus genus specific PCRs are there. So these are the difference. Otherwise, most of the time we do this pan-fungal PCR as well as, so that any fungus that is present can be identified. For example, in aspergillosis, you have many commercially available tests. See, in this particular, if you see, so most of the time, major common aspergillus species can be detected using multiplex PCR. So there are different multiplex PCR that has been available. It can also detect, see, if some of the kits can also detect the azole resistance. For example, in the mutation that is present in a CYP51A gene, it can detect this particular test. So, and also many of them targets they have not defined, but most common species of aspergillosis can be detected using by this test. Nowadays, more sensitive like duplex real-time PCRs are also available, so which can be done directly from a clinical sample. So Aspergillus again now recent recommendation, both all the guidelines they have earlier it was not there. Now PCR they have included as for for the diagnosis of invasive aspergillosis, especially from an ball sample as well as from the serum samples. So for Candida species generally people are not using much of this PCR test because beta-D-glucan as well as blood culture and other tests they use. But still in Candida, as you can see that at least 5 major species of Candida, most of the kits can detect this particular thing. So one of an important test, but this is an significant because it can detect candidemia within 2 hours after collection of the sample. T2 magnetic resonance. This is nanopore based test. It is an PCR test. Again, this particular test can detect only 5 different species. For example, in our ICU study when we did candidemia causes, there is more than 32 agents. So at least around 20% of the cases you may be missing if we use this particular T2 magnetic resonance. And so another 3 or 4 slides I have. For pneumocystis jirovecii, again, we do not have culture positivity. We cannot culture this organism. So PCR can be a very, very good test for diagnosing pneumocystis infection. We do have many of the kits. Again, we have a problem with the resistance. Some of the kit will also detect an resistance in this GHPS gene along with. For mucormycosis, again, we do want to have a PCR test because especially for pulmonary mucormycosis, it will be very difficult to diagnose. So many of the time, whether it is aspergillosis or mucormycosis. So both the treatment for aspergillosis is completely different, and mucormycosis you have to give voriconazole. So that's why it is very important to differentiate. So from the serum, this mucorgeneous test is there. Which can detect, and also now recently they have developed this COT gene has been detected which can be help in diagnosis of mucormycosis. So we do have a multiple test like detection of this most of the time, like Professor Dr. Rajiv Soman sir, they on other many of the reference we get when the patient is not responding, so they have found out in the histopathology, so it will be very difficult to we know only it is septate or aseptate, other than that we do not know what it is. So paraffin embedded sections is there, so in that we can, from using that we have evaluated many of the time, but you need to have a very at least 50 micron thickness tissues we should have, and you can see if you use both you can use ITS pan-fungal, and if you have an aseptate type, then if you can use in specific mucoral specific gene primers, and you can detect when you use an pan-fungal, we have seen that still 30 to 40% of an samples cannot be identified because DNA get degrades in the form due to the formalin. So film array, you know that after blood culture positivity only I can use this. You can use this particular technique. It is a syndromic test, and some other test like breath detection already early in the main seminar we have seen that. So this is an metabolite detection. So by using an eNOS, this one, many of the metabolites. So here you can see that specifically without patient without invasive aspergillosis, only in aspergillosis some of the volatile components have been detected. So these things by using certain devices, so you can help, that is still coming up. So next generation sequencing is the one promising one. So for example, few studies are available. So you can see that if you do, and especially this nanopore technique and all are there nowadays. So it is becoming cheaper and cheaper. So we can exploit this particular technique. Even in case of formalin fixed tissues, these things, this next generation sequencing have been used. So you can see that they have used a different morphological thing, septate hyphae, aseptate hyphae, and they have given a very clear cut identification in the next generation sequencing. So nanopore and other things can be used as an important technique for the diagnosis of invasive fungal infection. So thank you all for your kind attention.
Thank you, Professor Siva. We'll take the questions. Over 46 years of professional experience
Help me with this?
and has achieved remarkable milestones in the field of infectious diseases and HIV medicine. His academic excellence is evidenced by numerous awards. If I read out all the accolades that he had received, it will take time. So, from being awarded the Best Resident Award at Chem Hospital in 1978 and 79,
That is
to being
prehistoric
awarded
period.
Fellowship of the Infectious Disease Society of America.
Sorry, thanks.
So, sir, you are requested to proceed with your lecture.
Yeah.
Thank you.
Good afternoon. Okay, good afternoon, friends. I have to disclose that I am the odd man out in this session, in this hall, in this whole conference. I am a clinician, okay, but I'll be discussing treatment, but I will definitely want to acknowledge that you folks are actually contributing so much to the diagnosis as well as the further treatment of the patient, as this case will show you. So really we have you guys coming to our rescue. So let's take this patient. This was a 60-year-old hypertensive diabetic, had a percutaneous nephrolithotomy for nephrolithiasis. Now this was done elsewhere in 2023, so July 2023. Now this was followed by a discharge of fungal balls or bezoars, as you may call it, in the urine. Okay, so periodically the patient was passing all that. So when he came to us, we did not us, this he first presented elsewhere. So there was a filling defect, as you can see here in the upper left calyx of the kidney. And this was the culture and the susceptibility testing of the material which was discharged through the urine, which was done fully almost 2 months later. So 2 months went before all this was happening. And this was the report which showed you that this is Aspergillus terreus, and this is its susceptibility. So it is reported as susceptible to voriconazole, isavuconazole, posaconazole, and so on. However, there was no response to oral voriconazole with proper therapeutic drug monitoring, so proper doses, everything was going on. So again, after another 1 month, a DJ stenting was done and a culture was repeated. And look at what has happened to this isolate. So it's the same isolate like Aspergillus terreus, but now it is resistant to both voriconazole as well as to isavuconazole. With this, the patient was referred to me for an ID opinion. And what would cross my mind? What can be advised now? Can we give this patient liposomal amphotericin B, or do a nephrectomy the left side, or give high dose voriconazole, or something else? And I'm sure you will agree with me that something else, okay? Because obviously this is terreus, there is intrinsic resistance to amphotericin B, and also you know that the liposomal or any other, the penetration into the urine is very, very poor, or a little shade better with the deoxycholate as compared to the liposomal. Nephrectomy, yes, but try and preserve an organ whenever you can. So that would be just the last resort. Now, there is no such thing as high-dose voriconazole. You are already operating at the upper bounds of the narrow therapeutic window. So there is, this drug does not have a good therapeutic index in that sense. That means it is not safe to give higher and higher doses. So obviously that is not a good choice at all. Again, also remember that although this is an azole, this is not concentrated very well into the urine. So it's hardly 2 to 3% level in the urine. So what can it be? So something else. So look at the PK/PD considerations and possibly consider combination antifungal therapy. I know Arunaloke is here. I'm having a little butterfly in my stomach when I'm talking of combination therapy, but I'll argue my case. Okay. So what do we understand by this PK/PD consideration? So the pharmacologist tells you what is the kinetics. Okay, so the relation of the drug level to the penetration and this phenomenon called hysteresis. All this tells you what is the level. It will depend on a lot of patient-related factors, absorption, bioavailability, metabolism, and so on. Okay, so the dosing will tell you what could be the kinetics there. That's only a part of the equation. The other equation is what you folks are very good at, and that is the pharmacodynamics part of it. Okay, so does it have an intrinsic resistance, or is there an activity? Is there reduced susceptibility? Is there tolerance? All these phenomena, I think you are very well versed with that. And what is the mechanism of action? And what is the degree of antimicrobial action? So that is measured, of course, by you in terms of what is the MIC, what is the minimum bactericidal or fungicidal concentration, what is the mutant prevention concentration. So how high can you go? Is there any post-antifungal effect? And also pay attention to the toxidynamics part of it. And when you combine all these together, the kinetics, the dynamics and all that, what you really have is this PK/PD index. So that will tell you what is going to be the microbiological effect. So is it going to be stasis, 1-2 log reduction? Or even more tantalizingly, can you have resistance suppression? In other words, you are suppressing or you are exceeding the concentration which is necessary to kill off the particular subpopulation which has the highest MIC. But even then, this is not clinical cure. Okay, so there is a further many more factors which are mainly patient-related factors which are going to determine what is the clinical outcome. Okay, so you might do all these thinking, but the patient outcome ultimately has many more factors, and all these factors, remember, are operating further downstream from these PK/PD considerations. So pay attention to what is PK/PD considerations. Here you are dealing with probably going to use an azole, definitely not going to use amphotericin B. You might perhaps think of using a 5-flucytosine and maybe an echinocandin. Also remember that it's not cidal for molds, not cidal for aspergillus, but it will have some beneficial action, maybe as an add-on drug. Okay, so we were treating this patient in 2023. This is a very new publication from November 24. But let's look at what it says. So this is combination antifungal therapy to the rescue. What is the potential and challenges of combining for reducing the morbidity and mortality in hospitalized patients with serious fungal infection? So certainly this patient is one who falls in this group. So taken together, this is like a meta-analysis, and all single studies have failed to decisively establish the benefit of combination therapy for invasive aspergillosis. And if you look at it, given the time and resources involved, it's really unlikely that a proper RCT will ever be conducted. And the only study that we know is about the Karen-Ma study in hematologic malignancy population, where it was found that a azole and an echinocandin together, specifically anidilofungin and voriconazole, did fare a little bit better, especially in patients who had a biomarker-aided diagnosis. However, there is more compelling preclinical data as well as observational studies which may suggest potential benefit. So the bottom line finally is you consider giving combination, especially for serious disease, especially in hematologic malignancy population, because the defenses are inadequate. For highly resistant pathogens, for those pathogens which are within the biofilms or in tissues with compromised drug penetration. And it goes without saying that this patient of ours really qualifies, because all these things which I have said there, which I have underlined, are operating in this particular patient. So let's look at what are the factors here. So you have Aspergillus terreus. Where is the infection? It's in the kidney. It's also there in the urine. And what are the agents that we have for this patient? So we have amphotericin, we have the 3 azoles, we have maybe micafungin or one of the echinocandins, and we have 5-flucytosine. So let's look up how each one of these would be faring. So obviously, Aspergillus terreus, so no role for amphotericin B. It will reach well in the kidney, not in the urine, so not at all for further consideration. Now this patient was treated with voriconazole, but the bug has now become resistant. It did not work, resistance has developed. What about isavuconazole? Again, it is now resistant, so very unlikely that it will work. Now remember, both vori and isavuconazole are compact azoles, they are smaller molecules. Okay, so they do not have that many binding sites to the CYP51A, and therefore resistance can easily develop. And this particular mutation called G448 can produce cross resistance between these two azoles, but not with posa and itraconazole. So posaconazole, yes, it could work here, it could perhaps work in the kidney, obviously not much in the urine, it's not really excreted in the urine like fluconazole is, but you'll have to make do with it, and maybe high dose may work. So there is something which I like to do, and that is to give a high dose one of these azoles which are relatively safe. That may work, it has multiple binding sites. What about micafungin? I already pointed out that it doesn't have a sidal action. And again, it doesn't work in the urine. But among the echinocandins, it is the best for penetrating into the urine. Also remember that urine has less amount of protein. And this drug is highly protein bound. So since you have less amount of protein, there is more free drug in the urine. So perhaps it might work a little bit in the urine. Although it might be suggested it won't work. And what about 5-flucytosine? We don't know much about it. For Aspergillus terreus, will penetrate well into the kidney, certainly will penetrate very well into the urine, and there is some interesting part here. The urine has acidic pH, okay, and there is this fungal permease which functions very well at acidic pH, whereas you guys test it at neutral pH, I suppose, and you find that it's not working. But there is a chance that it might work in the urine for this reason. So based on all these considerations, I planned a triple therapy with high-dose posaconazole, micafungin, and 5-flucytosine, with the notion that I might be able to avoid a nephrectomy. But remember that this is all based on very, very extrapolative considerations. And when you extrapolate thousands of feet, you could sometimes land up with this kind of trouble. So we are always going to do this with some amount of trepidation. But it somehow worked. So for 2 months, there was no more fungal ball discharge. The urine culture turned negative. So we stopped the micafungin after 2 months. The patient obviously would beg you to stop it. He developed fever, possibly due to that high dose of posaconazole, but we reduced the dose to 100 BD, which is a little lower than the standard recommendation. But the level was still reasonable. So it was 1.6, but otherwise my preference is for a level of 3 or so. Now this patient also developed a new onset nephrotic range proteinuria. So this was a nightmare. You know, on one hand I had set out to avoid nephrectomy. And am I going to land up with renal failure or some such problem? But fortunately, no other features of pseudo-hyperaldosteronism, which is one of the important adverse effects of posaconazole, were not seen in this patient. So he just plodded on, and since there were really no alternatives, posaconazole was continued with a close watch. The next question is, how do I assess the termination of treatment? What is the real endpoint of treatment? And that's something which is going to be difficult. So again, go back, clinical, radiological, microbiological. So in terms of culture, maybe PCR, maybe biomarker. And here again, you did something unconventional. Let me talk about that. So remember that low-level galactomannan can be detected in urine in patients with systemic invasive aspergillosis. So I sort of reasoned that if you have something which is urological, so you have urological aspergillosis, what would be the galactomannan in the urine? I would have expected it to be quite high in the urine, and if that has become low, maybe that is something which we can use. So it's really unknown whether you can really use it in urological aspergillosis to assess either diagnosis or to assess the end point of treatment. So what happened? Yes, clinically no more fungal balls were discharged, so clinical good. Radiologically also good, that particular ball which was seen in the calyx and all that had gone away. Urine culture had become negative. So we did a serum as per galactomannan, which was negative. We also did urine. I had to request Shauli, who is sitting here, to do all these things. So this is not, a CAP accredited lab is not going to do it. Only because of our good relations they did it. And really we can't really even interpret it, but it looks like a low value. So I think maybe that something is working. We also did a aspergillus PCR in the urine. Okay, so by all accounts, we thought that now things are okay. So the patient received all treatment for 3 months, and now we have a follow-up of almost a year or longer, and the guy is quite okay. So the messages from this case is managing this kind of a difficult to treat mold infection, which is involving the kidney as well as the urine, remember, needs appropriate samples, and they have to be done repeatedly. Antifungal susceptibility tests and drugs, obviously, and unconventional triple therapy may be needed, and I am open to criticism from all of you for a prolonged duration. Unusual adverse drug reactions during the course of all this funny treatment can also be encountered. And finally, even unconventional off-label tests may be needed for assessing the response after convincing the microbiologists. Nosocomial, so remember this has come after that procedure. Okay, so this is indeed a nosocomial aspergillus staphylococcus infection. So after PCNL really indicates a gross breach in aseptic technique, and all of you are all infection control vigilants. Okay, so you would not be really happy about this thing happening here, but this is the reality. So attention to surgical asepsis really cannot be overemphasized. So I'll close by saying that managing such a case, I think it's a difficult case, is like a team sport, like soccer. The microbiologist passes on the identity of the organism, indicates its susceptibility or resistance, and does that repeatedly during the course of the illness. The pharmacologist passes on the properties of the drug, and so finally it remains for the simple-minded clinician like me to just take aim and shoot. Thank you.
Thank the organizers and the chairperson for giving me this opportunity to discuss this last episode, last fungal infection of this session. So we have learnt about all the invasive fungal infection and very deadly. This is a superficial, considered to be a benign fungal infection of the keratinized tissue. But as we go on looking at the slides, will you agree that it is considered anymore a benign superficial fungal infection? You will change your opinion. So looking at this, over the last 6 to 7 years, there has been an unprecedented increase in number of tinea cases, and they have been very slow to respond to the conventional antifungal drugs which are available, that is the terbinafine, etc. And the factors that have been attributed to this kind of bizarre clinical presentation was a therapeutic challenge to the dermatologist, and these are various factors. Some said it is a lifestyle, changes, wearing tight clothes, and humidity. Of course, there are all these factors are there, but one of the clinicians observed that there is an excessive use of steroid over the counter, and the steroid modified infections of the tinea were very, very bizarre, and this was an atypical presentation where the clinicians were shocked and they were not responding to treatment. So this is a case, if you see when they use a steroid like clobetasol and mometasone, it produces very extensive concentric rings which is presented as tinea imbricata, pseudoimbricata or indecisiva. These are strong concentric rings and they spread to large areas of the body. And this kind of an atypical presentation of tinea was later given a term. When you see the body surface area, they are covering large areas, and very soon this term was introduced, which was known as recalcitrant dermatophytosis, which was including, they said, all these chronic, persistent, relapse, recurrent, these infections, which has taken worldwide as well as in India, was a huge challenge for the clinicians, for the dermatologists, is what has been happening. For the last 7 to 10 years, this suddenly became a radical change in the presentation. So, these definition I will not go through. You can look at this paper. They have then, the ectoderm and the dermatologists and microbiologists have gone through and defined all these cases that treatment beyond 6 weeks, and they are coming back with recurrences, and even newer lesions at the same place or at new places were called as recalcitrant dermatophytosis. So there has been a radical change. What has happened? There has been, and we consider that dermatophyte probably has undergone a huge revolution. And there is a radical change in the shift in the etiology. If you see a world map, this is a paper where we have collected the etiological predominant agents which were in 2014 or in 2003, 10 years ahead, 10 years back. So there were a predominance of T. rubrum even in US. So these cases are now declining, and most of the worldwide cases are now being overtaken by this new dermatophyte, which I will tell you that taxonomically there has been a change in it in the nomenclature as well. So this map just shows you, if you look at the Indian map, it is a dark colored, it is like an outbreak. They announced it, and this etiological agent was termed as Tinea trichophyton interdigitale. Now this belonged to the mentagrophyte complex, and together it was known as TMTI, that is T mentagrophyte interdigitale complex. And slowly there were several papers, lot of work has been done by PGI Chandigarh and Patelchas. There are several papers continuously. The clinicians as well as the mycologists were working and trying to figure out whether it is the original T mentagrophyte which we had earlier with a spiral hyphae, or is that it has undergone any evolution. So yes, there has been a change in its clinical presentation, definitely they are seeing that, and this etiological agent has also undergone an evolution. So Microsporum canis is now found to be worldwide in areas where there are pet-loving countries, whereas interdigitale TM complex is now by phylogenomics has been considered to have a geographical identity, very specific geographical identity. It is found extensively in India and in Iran, and now it is spread all over the world in Australia, Vietnam, Japan, US and in European countries. So this ITS, as Dr. Shivaprakash has already said, this is by phylogenomics. They have identified that this is the mentagrophyte which has undergone evolution, and there has been changes, and this has now become very anthropophilic and adapted to the human body. So now this paper tells us that there has been a sharp increase in cases from 2011 to 2021, and India probably provides an environmental niche for these organisms to survive and proliferate. And this tells you that in India there were large number of cases which came from, reported from Delhi, Rajasthan, Tamil Nadu, Chennai, and all across. Most of the countries were reporting sporadically, but these were the heat map shows that these were the concentrated areas where a lot of these mentagrophyte with a different morphological features as well as drug resistant features were being reported. So you see from 2011 to 2021, this was a retrospective data collected that the T rubrum was completely being replaced. Now it is like 53 to 60% is T mentagrophide interdigital, and 40% is just T rubrum, followed by Microsporum gypsum and verrucosum. So this is how the evolution of this dermatophyte has occurred, and this dermatophyte is found to be very drug resistant. Drug is the drug of choice. The terbinafine, which was the drug of choice for tinea infection, this became one of the largest challenge, a therapeutic challenge for the clinician. And the clinical presentation of this was very typical. They were actually affecting the glabrous skin of tinea corporis, cruris, and fasciae. So this was the three general areas where they were predominantly affecting, and a large concentrate, huge body covering, huge body surface area. And the terbinafine resistance was started being reported from all across the country. So from worldwide, 2015, Yamada et al. Was the first one. He saw in few strains, and then all across the India, mutational studies carried out found that terbinafine resistance is being reported. Taxonomically, finally, the taxonomists and the nomenclature scientists, they probably hypothesized that tinea mentagrophide is actually zoophilic, and there has probably an interspecies, a barrier has been broken, and this mentagrophide now has undergone interspecies barrier chain and anthropization. Anthropization is adaptation to the human body, and this TMTI complex, and very recently it has been annotated into tinea indotinae. So indotinae is just a clonal offshoot showing very high virulent and terbinafine resistant trichophyton. So it's not scientifically very clear, but practically, yes, they want to say that it originated from India, but there is still a debate. So this probably has broken the barrier, and now it has become anthropophilic adaptation. So this I've already told. There are several papers on which, based upon various genes sequences, they found out that it is just a clonal offshoot and undergone an anthropization, and now it is only adapted to human circulation is there. It is not a zoophilic. The T mentagrophite is only zoophilic, whereas the TMTI complex, which belongs to the genotype 8. So there was a Peter Nenoff is a dermatologist from Germany, and several other papers from PGI Chandigarh. They have found that the TMTI complex, it is divided into 9 genotypes. So 1 to 9, it is the 8 genotypes which is considered to be the this clonal offshoot of the TM complex, which is the one which is causing this kind of an epidemic across the country. So if you have to tell clinicians, it is TMTI genotype 8, which is existing worldwide and in India. So these again tell you that this is the genotype which is common, and several countries across the world have found mutations. So if you look at the database, there are a lot of mutation studies have been, they have deposited their gene sequences, and these are available. So, so this is just to summarize that by nomenclature, it is an Indian clone Indotini. And of course, again, I'm saying that this nomenclature does not make any sense, but this is the genotype 8, which you must remember. Now, this is like a case, a recalcitrant tinea cruris, where a patient, like Sir just now said, Dr. Rajiv Suman, the patient is given so many antifungals. So you see from 2 years, the patient has been taking clotrimazole local, topical, as well as on systemic antifungals. So terbinafine, on fluconazole and grisophulvin. So this is one reason, and when you do an MIC, you will see that there is a rise in the MIC level. I will come to the antifungal resistant pattern. So one of the reason, it is just not that this strain is resistant because of antifungal resistance. There are several other factors, but this is one of the reason that any patient who comes with previous history of antifungal usage, the clinicians are now recommending that avoid that antifungal which has been excessively used. So if the patient has already been on azoles, so if you start an azole, be ensured that that strain must be having an efflux pump and will throw out the azole. So you have to start a new drug, and which I'll tell you in the later slides. So clinical resistance and pharmacological resistance are different. Microbiological resistance is just telling you the MIC, which is high. But does that correlate with your clinical resistance or not? Clinical resistance is clinical cure. So now the clinicians are using clinical scoring. So if the lesions, there is a scoring method, so 0 to 5 they give satisfactory, 5 to 10 they give average, and more than 10 they give it clinical scoring, they give it unsatisfactory cure. So it is just not microbiological cure, they need to see the clinical cure. And resistance in clinical aspect, there are various other factors, as PKPD has already been discussed in the previous lecture, and potency of the drug and suboptimal doses. So various factors have led to the emergence of this mentagrophite into this kind of a villain. And this is how it looks like. Phenotypically, it is very difficult to differentiate from mentagrophite. There are some orangish background, but you have to do a sequencing to find, as he said, Dr. Shiva, that it is ITS you have to do and sequencing, or there are various kits are available where you can, MALDI-TOF can also detect the interdigital complex. So this is where you see, this is a paper from PGI Chandigarh, where there has been a shift from T. rubrum to T. mentagrophite. Now, the culprit is just not a simple it is not just a simple superficial fungal. This organism has evolved, and if you look at the virulence of this, it expresses these many number of enzymes. There are plenty of proteases and extracellular vesicles. So you know that it undergoes, immediately after addition, it releases its hyphal form, and there are excessive of protease. So there are papers where they are saying that if under sub-concentration, sub-MIC concentration of antifungals, we have given chance for this dermatophyte to proliferate. And it is now expressing so much proteases that it is like a protective barrier. So and if you look at this next slide, T. rubrum has already been studied very well, that there are many proteases and many enzymes it secretes. Look at this. There are 575 types of proteins, endoproteins, exoproteases, and extracellular vesicles, which we did not even underestimate that this dermatophyte can express. And this was a study in mentagrophite, and these isolates that we studied, we found that there are metallocarboxypeptidases. So this is one of the targets. If newer drugs have to be used, we need a target where protease expression has to be reduced. So there is excessive production of proteases by these pathogens. Now coming to antifungals, CLSI and UCAS, they have only given ECOFs. There is no clinical breakpoint. So this is where the caveat is that we need to understand whether looking at the MIC, the clinical cure can be correlated or not. So MIC resistant strains does not always predict a clinical failure. Breakpoints need to be studied. And now if under concentration of MIC, under sub-MIC concentration, that means if you are giving low concentration or suboptimal dose of the antifungal, the dermatophyte will develop tolerance. So tolerance is they may not be undergoing any mutation. So tolerance means they may not, the dermatophyte may not be undergoing any mutation. But resistance means the fungus is undergone mutation, and that can be identified. So in tolerance, the fungus will survive even under high presence of high antifungals. So there has been an alarming rise. Terbinafine resistance has been reported worldwide, and there have been hotspot mutations. And in India, it has a very geographical niche where these highly virulent producing endothelial or TMTI complex, these have shown to produce excessive proteases, and they are multi-drug resistance. Not only to terbinafine, they have been found to be resistant to azole and grisofulvin. So terbinafine resistance, and there are several papers where they have found hotspot mutation 397 and 393. So it is the ERG1 mutation. In fact, if you look at this, that 0.06 microgram per ml concentration used to kill Terbinafine has both static and a sidal effect. This used to kill the fungus. Now the MIC has risen to more than 2. So this is one of the things which is very alarming, and sequentially we have given the chance for the dermatophyte to develop, to gather this kind of a mutation and resistance. So patient failure to terbinafine in naive, it acts as a sidal activity with a T half of 16. Within 16 hours there is a cure rate. Whereas if you continue to do this, the new keratin which comes out, keratinized tissue, they shed, and then a new keratin, it has been found that on prolonged usage of terbinafine, the new keratin is also resistant to the terbinafine usage. So molecular mechanisms, you see the hotspot mutations are there, which has been listed in the last. So 393 and 397 are the mutations which are constantly being associated with high MICs of terbinafine. And you will see plenty of papers where they have seen that if this mutation has occurred, so all alanamines will not work for this dermatophyte. So this already has been shown. Efflux pump as well as the ERG1 mutation and ERG11 for azoles is factors of acquiring mutations in the dermatophytes. And these are again where everywhere across the country these mutations have been reported. This is a PGI's paper where they are saying that the MIC up to 4 microgram is considered to be very high, is correlating very well with 397 mutation. And they have also, this is also an ours paper, we have found the similar kind of association with high MIC. So again, this is interesting paper from PGI Chandigarh where they have used ARMS PCR. Now, any of you see tertiary care hospital doing an AFST is not possible, especially for a dermatophyte infection. So what are clinicians doing now? So clinicians have recommended that if a case is naive, you go ahead with your empirical treatment or your judgment, considering the, the skin condition and the patient's weight and previous history of any intake of antifungal. But if a patient is coming with recalcitrant tinea and previous history of terbinafine usage, then better that you do a culture and go for an AFST so that you are able to find the MIC level, although again that 90-60 rule stands important. Now, this is one of the best papers which I have seen that they have in Chandigarh. They have done 498 isolates and they have looked at MICs of 13 antifungals against this TMTI agent, and they have found, they have identified, because there is no clinical breakpoint, so they have identified an upper limit for the wild types. So if an upper limit wild type has been identified, if you keep that as a reference MIC, anything higher than that in your own labs can be considered as a failure to treatment or high MIC. So this is how they have done. Upper limit has been, you can read this paper, and very interesting, where they have found out, and probably because with this paper they will go on to find clinical breakpoints also. Azoles, yes, azoles is again ERG11 and overexpression. Please remember, it's not just ERG11 mutation, there is overexpression, and we found that there is excessive ERG11 overexpression by real-time PCR. So even the azoles will not work in such patients, and these are several papers where you see everyone has reported these mutations and these hotspot mutations. So 397 and 393 are the main villains, whereas the 420 and the others 415 mutation, they have found that if these mutations occur, then higher dose of terbinafine can be given to these patients and they can be cured. So there are certain very strict mutations which will not allow the usage of terbinafine. This is their recent paper where they have seen that if these are mutations other than 397, 393, and if the MIC is high, then higher dose and prolonged duration of that treatment to be given. TDM, I do not know. Now the drug of choice has become itraconazole for these patients, and you can then take a chance on terbinafine or grisophulvin. Now TDM serum levels will not give you a very impact on the dermatophyte infection. You have to, like sir said, tissue levels. We have to see the tissue concentration of these drugs. And this is how there are multiple factors. This paper tells you there are multiple factors which is leading to the drug resistance emergence of an highly virulent TMTI, which has caused this kind of an epidemic in the country. So chronicity and possible atopic. Now, when you are taking, dermatologists have said, if the patient is atopic, there is a high immunoglobulin E, there is a chance of chronic inflammation. So you have to treat that and reverse that IgE, otherwise they will continue to have a immune response which is not favorable for their, with the treatment. A time to think for antifungal resistance, the line says that failure is not related only to drug resistance. We have to take it into whole. There are a lot of other factors. Biofilm production is in the nascent stage. It produces, yes, in nail infection as well as in dermatophyte. It's a very simple method like in Candida. And we found that even, I think Ramachandran SRM has done a work on dermatophytes, that biofilm production is a directly correlated, the density of the biofilm is directly correlated with high MIC. So this has to be again, but when we looked at the responders and non-responders, it did not correlate. So I think we have to do future studies to find out whether biofilm, because once a biofilm is formed, then none of the drugs are going to act, and the fungus gathers a lot of tolerance and fails to respond to the treatment. Last is very sarcastically, Hinan et al. Has said that this is a keratinized fungal infection and it is a very low immunologic profile. This dermatophyte has a very low immunologic, does not create any immunological changes. We need not worry. But if you look at these slides now, so as papers have shown that if there is an autosomal recessive, especially in CARD9, a deeper dermatophytosis infection can also occur. Innate defense mechanism is very helpful. If the conidia and the inoculum is small, phagocytosis, the conidia can be removed. So clinicians say strike when the lesion is small. Don't make it into multiple. That is what we have to teach the patient. There is a lot of harm reduction and education that you need to tell the patient. These are various PRRs, the pathogen receptors, where this is happening in dermatophytes, mind you, and it's not that it does not mount any immune responses. So here also the T cell is very important. The T cell CD4 immunity is very important for it to clear the infection. Now, this was a small study that we did, that CD4 can polarize either into, we all know this, PGs, TH1, TH2, TH17 or T regulatory cells. So here what is it, that if there is a TH1, it will clear the infection. But if it is continuing for a long time, TH1 and TH17, the inflammation, so these huge lesions have chronic inflammatory response. That is why the inflammation is also so high, the antifungal is not able to bring down the lesion, bring down the response. So the lesion with inflammation also has to be, you need an anti-inflammatory also. So very complex that they are hitting their hemostasis, T regulatory, TH17, they are fighting each other. And we did a small test in trichophytin antigen testing, and we found that intradermal testing, they are all responding with an immediate hypersensitivity reaction. The CMI was knocked out completely. So there is a paradigm shift. TH7, this is like a PBMC, we treated with trichophytin antigen, and by flow cytometer we found that there were several cytokines, mostly TH1 and TH17, both were fighting for each other, and T regulatory cells were unable to control the inflammation, especially in the acute cases. So this is how we did TH17, T regulatory, all were considered, were found to be high. And this is our latest project where we did a transcriptomic and we wanted to find the expression. And this is just under communication where we found that TH1, TH17, there are several genes which have found to be overexpressed. So while an acute patient comes with a lesion, we must keep in mind there is an acute inflammation which is going on. So that inflammatory response should also be, and it is no longer a very low immunological agent. So how much we know? We don't know much. And this year we need to know that we have to reverse. Either we bring down TH17 and bring back the TH2 to TH1. So this is little complicated. Lastly, I want to say dermoscopy has a lot of role to play. Because here they are finding vellus hair. Vellus hair are those thin hair which are on the skin, on the face. And if there are conidia, dermatophytes within the vellus hair, then you will be treating only the superficial skin infection and not treating the hair. So dermoscopy has its role. So you should read the ectoderm consensus, which tells a lot of recommendation. So how patient should behave. Naive tinea, go ahead with the treatment, whereas in recalcitrant, you need to first do a QH culture and prolong the treatment duration and increase the dose. Terbinafine to be used as a second choice and itraconazole. So in conclusion, it is still a major problem. Clinical breakpoints have to be identified. Monitor these patients, very important, and talk to these patients and educate them. I think that is all. And immunologically, we need to really consider that anti-inflammatory should be given so that there is lowering of the inflammation. Thank you so much.
Thank you, Dr. Shukla. Now the discussion is on Dr. Shivaprakash.
If you are saying anti-inflammatory to given, then the people are doing very good, giving steroid along with your antibiotic. But that is increasing this.
No, so the I mean to say not steroid. The terbinafine, the drugs itself have anti-inflammatory. Choice of drugs should be there, like the local sertaconazole.
But the thing is that if there is anti-inflammatory to be given, you say this comment.
No, it is not steroid, sir. The sertaconazole, laliconazole, these have anti-inflammatory effects. So not steroid to be given. These local topical antifungals have anti-inflammatory. So you must use both systemic as well as local antifungals to be used. If we have to reverse it, not steroid, it will depress the immune response completely.
I have a question to that is there. Do you need to cure that? And if it is to cure, what is the best way to do it?
If it is found as asymptomatic candida, there is absolutely no reason to treat it. It's only, I think it's something very important. I don't see any intensivist here, but otherwise that's the common situation where you find a urine culture in an ICU patient who is already has been catheterized. You find Candida auris and you start jumping about, trying to treat it, make a ID reference, but we will tell you not to treat it. However, it's a person who is colonized, and so you will need all possible methods which are difficult to decolonize, but at least infection have to be heightened to prevent cross transmission to other people. So that is frightfully important. That one-to-one nursing. At least I am happy to say that in our hospital we don't have a single case of Candida auris transmitted locally. We have only patients who are coming in from other institutions where we find that, but then we have not had a outbreak or the next patient has not got. So I think all this infection control colleagues are doing a good job. But isolated Candida auris in the urine, not to treat. And you don't even have the tools to treat. So that is another thing, because there is no use of fluconazole. 5-flucytosine on its own will never work.